Assalamu alaikum. We're continuing the video about interocclusal space and now we're talking about solutions. In the first video we have talked about reasons and now we're talking about solutions. Now we said that the problem of interocclusal space mainly goes where or occurs where we don't have space to add restorative and prosthetic components of teeth. Okay, so I don't have space to add this tooth. This tooth could be added by a partial. It could be added by a complete denture. This is a partial denture. It could be added by an implant. It could be added by a bridge. These are for missing teeth I'm talking. A bridge. It could be a broken down tooth and I want to add a crown to it. Okay, so I have a restoration and I don't have occlusal space to add to this area. Okay, so what are my solutions? We said first of all that remember that we have what we call the occlusal vertical dimension. This is vertical dimension, and we have a freeway space, and this is the distance between the teeth during non-functional contacts. Okay, so we have a freeway space. Where am I going to work to add interocclusal space? Okay, interocclusal space solutions usually occur where I have remaining contacts. So my addition contacts. Okay, so if I'm going to add, I'm going to add at remaining contacts. If I'm going to remove, I'm going to remove from areas of over-erupted teeth. Okay, when I'm adding to occlusal contacts that occur at the correct vertical dimension. But there is another way to add inter-arch space is by decreasing the freeway space and adding vertical dimension. So this is a general solution. So we have local solutions in over-erupted teeth, or we have general solutions. They could be to the jaws where we reduce the freeway space and add to the vertical dimension, or we change all of the remaining occlusal contacts, and this happens in full mouth rehabilitation cases. Okay, so let's talk about them one by one. Suppose my problem with the interarch space is opposite to a single tooth. This is a single tooth that had over-erupted. It's not with the occlusal table of adjacent teeth, and it's also not following and not maintaining the occlusal table of the lower teeth. So we have a single tooth problem. So it's single tooth. What do I do for a single tooth? I have multiple solutions for the single tooth. One option would be extraction. Okay, I could extract that tooth if it's called elective extraction. If I need to extract that single tooth because it's over-erupted and it's not one of the main teeth that I'm depending on. For example, it's an over-erupted 8, it's an over-erupted 7 that I'm not going to restore the opposite of it. I'm going to depend on a short dental arch. So this is solution number one. What am I going to do? I'm going to extract it altogether. The second solution is the most conservative. This is the most destructive. The most conservative is keep that tooth, but put it back into location by orthodontic intrusion. What do I mean by intrusion? Is taking the tooth and putting it back under orthodontic forces, putting local forces on the tooth on its own, and letting it go into place. These forces could be added by, if it's a maxilla, for example, maxillary molar, I could simply add a bracket to it and add the component, then add something extra oral as a band on the head, and it will guide the forces on the tooth itself. I could also do it by placing mini implants. These mini implants are placed high in the sulcus. They connect it to the tooth with specific bands. The tooth has itself, it has a bracket, and these bands, you could have multiple if you want. You can do a single band or multiple mini implants, and those implants are placed away from the root of the tooth, and they drag the tooth back up. So this is the most conservative. This is the most destructive, extracting the tooth altogether. Can I have something midway? Yes. This tooth is over-erupted. Not only over-erupted, part of the root morphology is appearing. Okay? So the roots are there. The crown is here. It's over-erupted. Let me just... So part of the root and part of the tooth is over-erupted. And sometimes it drags the gingiva with it, or sometimes the gingiva is recessed. So you have these two options, where the dentoalveolar complex follow the tooth, or you have the case where part of the root is exposed. So these are situations. What is the problem with such case? That this tooth had interrupted the occlusal table. This is the original occlusal table. Okay? If I want to go back to put this tooth back in, it depends on how severe it over-erupted. If suppose it was only small amount of over-eruption, simply I could reshape the enamel and put the occlusal table back together. But if I'm going to put it back into the occlusal table, I find that I'm indenting. That means I need to place a crown. Can I place a crown and a very short remaining clinical crown? No. Sometimes I have to go with surgical procedures to increase the height of the core of the crown, and by that I need dentoalveolar surgeries, periodontal surgeries, where I am doing some procedures for the bone and the soft tissue. What about the pulp? Sometimes my reduction of the over-erupted tooth, I'm interrupting and I'm going to the pulp. So here I also have to do elective endo. So this case is a complex case where I'm putting the tooth back into location by preparing the tooth. So it will include multiple procedures. So what are the procedures once more? They can be enameloplasty. Okay? If we have a very small over-eruption, we want to put the tooth back into the occlusal plane of the adjacent teeth, enameloplasty. If I'm going to go into dentine, I will need to do crown. If I don't have enough core for the crown, I need to do periodontal surgery where I'm doing crown lengthening procedure. Okay? My reductions on the occlusal surface, I approach the pulp, I will also need endodontic treatment, elective once more. Elective endodontics. Okay? It depends on how much of the tooth I'm going back to go back here. Once more, I need to manage the soft tissue as well. And there's another problem with the preparation here. When I'm doing a crown, also make sure that you do modified crown finish lines. Finish lines. Because now I'm making my finish lines on the roots, not on the crown itself. So my finish line should be as conservative as possible, preserving as much tooth structure, and we prefer to have either zirconia 0.5 preparations or alloys. We use alloys here. So the finish line in the crown, you also have to modify it to adjust, because now we're preparing on the root. Also, the morphology of my finish line should change, because when I'm doing a crown, usually if I'm looking occlusally, we don't have a bulge here. But when I go to close to the root, I'll be preparing close to the furcation area. So I'll need to do this morphology, following the morphology of the root. Okay? When I'm doing my preparation. So these are the adjustments if I have a single tooth preparation adjustment for lost interarch space. So either extraction, conservation by orthodontic or intrusion, or altering the tooth shape by enameloplasty if it was minimum, crown if it was endodentine, periodontal surgeries of crown lengthening could be involve soft tissue only, or soft tissue and bone. And if I'm invading into the pulp, I need to do endo-elective procedures, and I have to modify my finish line of my crown preparation. These are the solutions for a single tooth invading on the interocclusal space.